Hello, and welcome to the second installment of the American Foundation for Suicide Prevention's Health Equity Summit. I'm Vic Armstrong, Vice President for Health Equity and Engagement with the American Foundation for Suicide Prevention, and I will be your host for today's webinar. For those of you who were able to join us for the first webinar of this three-part series, thank you and welcome back. For those who were unable to join for webinar number one, fear not. You can access that recording on our website at afsp.org/theupright, and I'll be sure to drop that web address in the chat. For anyone who is unfamiliar with the American Foundation for Suicide Prevention, or AFSP, we are the nation's largest suicide prevention organization with 73 chapters across the United States. We have chapters in all 50 states plus Washington, D.C. and Puerto Rico. We are also the nation's largest private funder of suicide prevention research. As a leader in the suicide prevention space, AFSP recognizes the importance of access to suicide prevention resources, particularly for populations and communities who have historically lacked such vital access. We believe that access is about more than having physical proximity to more of the same traditional resources. It is about having access to resources that are culturally relevant, relatable to the lived experience of the community being served, and perhaps most importantly, resources that a community is willing to utilize. With that in mind, AFSP has embarked on a health equity initiative in which we will use our resources, relationships, and position to catalyze both local and national efforts to address inequities. To address these challenges, AFSP recently launched The Upright, a collection of AFSP's resources, including research, programs, and policy that aims to advance health equity in suicide prevention. The Upright is a part of AFSP's commitment to support communities with disproportionate impacts related to suicide. Creating The Upright stemmed from research that tells us that developing suicide prevention strategies for underrepresented individuals needs to be anchored with the understanding that communities have unique lived experiences and need to see their experiences and identities reflected in the resources addressed to serve them. As a part of the Upright launch, AFSP is hosting this three-part series that brings together local and national experts who are connecting communities and driving change in the suicide prevention field. The idea of this initiative is to move the needle on health equity in suicide prevention by reframing and identifying health equity as a population health approach, and by both encouraging and facilitating support for communities to build their suicide prevention programs with sustainability and transferability, as well as creating pathways to help community-based or community-informed programs to become evidence-based programs. So again, welcome to AFSP's Health Equity Summit. Let's begin. It is my honor to introduce a colleague and friend, Dr. Sonya Richardson, Assistant Professor at UNC Chapel Hill, who will introduce our panelists and facilitate our Q&A. Dr. Richardson.
Thank you so much, Vic. I would like to welcome everyone to this webinar and express how exciting it is to come together to discuss health equity, access, and suicide prevention. I'm happy to introduce our three speakers that we have for you today, and they each share expertise in very unique and interesting areas. First, I would like to introduce Dr. Pierluigi Mancini. Dr. Mancini is the president and CEO of the Multicultural Development Institute. Following Dr. Mancini, we will hear from Dr. Dana Prince, Associate Professor of Social Work at the Mandel School of Applied Social Sciences, Case Western Reserve University. Last but not least, we will hear from Mr. Jeff Winton, founder and chairman of Rural Mind. Each of these speakers will speak to us for about 8 to 10 minutes, and then we will follow that up with Q&A from the audience. Please feel free to post any comments and any questions that you have in the chat. And as time permits, we will try our best to get to each one of your questions. So without further ado, we're going to start with Dr. Mancini. Thank you so much for being with us.
Thank you, Dr. Richardson, and hello, everyone. Thank you for taking time to be with us here today. And thank you for giving me the opportunity to speak on an issue that is both deeply personal, but also deeply urgent: the role of culture and language in determining whether immigrant communities can access or be excluded from suicide prevention resources and support. Let me start with the simple truth, but something we cannot afford to ignore. Suicide prevention cannot be effective without cultural and linguistic relevance. If the words of help don't reach the person in their own language within their cultural understanding, then that help might as well not even exist. My name is Pierluigi Mancini. I'm a clinician and an administrator with a mission to build an infrastructure in this country to provide mental health and substance use disorder services to those with limited English proficiency and those who are deaf and hard of hearing. In my work and in the stories of immigrant families, across this country, we see over and over again that language is not just a communication tool. It is actually a gatekeeper. We see families fleeing violence, seeking refuge. They may survive the journey, but then find themselves unable to access even the most basic mental health services when they arrive. Now, why is that? Because the system assumes that if you cannot speak English, that you cannot be heard, or worst, then you don't deserve to be served. Today, we're watching harsh immigration enforcement policies, and these leave families living in a state of chronic fear. The fear is not theoretical. It's measurable in anxiety, depression, PTSD, and yes, suicidality. For children, the separation from parents, the uncertainty of detention and the threat of deportation lead to lasting trauma, poor academic performance, and emotional distress. The trauma is compounded by the lack of access to culturally and linguistically competent mental health services, especially in detention centers and border communities. We have one of those detention centers in Georgia, and time again, I'm denied access to even go and talk to the people that are being held. I was asked to contribute a chapter along with one of my most respected mentors, Dr. Sergio Aguilar Gagiola, for a recently released book, Mental Health Equity. In our chapter titled Innovative Models for Mental Health Equity, we describe two paradigms of service delivery: the waiting mode and the seeking mode. Most behavioral health systems today are in the waiting mode. They're waiting for people to walk through the door, ask for help, fill out intake forms in English, and trust the system that currently or maybe historically has harmed them. But in communities with language barriers, documented, mixed, or undocumented status, or with cultural mistrust of institutions, people don't or they just can't come forward. That's why we must shift into a seeking mode, where systems go into communities, they listen first, and they co-design culturally centered responses. That's what we did. I founded and ran a multilingual, multinational behavioral health agency in the state of Georgia. Before we built any of our programs, we held focus groups in Spanish, in Portuguese, in English for the communities that we were serving. We conducted interviews in their language by people who were fluent. And we placed our services right in the middle of the community where people can easily access it. That's how we build mental health equity. We bring the services to the point of need, and we don't expect people to overcome every obstacle just so they can be seen. Culture is often treated as a challenge to be worked around. We hear people talk about, well, that's not culturally relevant. We got to figure out a way. But it's not a barrier. Culture is actually that bridge. When we design suicide prevention programs that include traditional healing practice, we're not diluting science. We're amplifying the reach. Culture gives meaning to healing. And then language gives it clarity. Programs that succeed in these communities is because they're culturally rooted and linguistically accessible. They recognize that trauma lives not only in the mind, but in history, in community, and in the lived experience of racism, displacement, and exclusion. There is an added challenge that we often have to face, and that's data. The data used to inform policy and funding often erases non-English speakers. If there is not someone in the room that's representing that community, it goes ignored. In national suicide prevention strategies, we rarely see disaggregated data that reveals the unique struggles. For example, Spanish-speaking Guatemalan farm workers in Georgia or undocumented LGBTQ plus youth in Texas. If the data doesn't see you, then the solutions won't see you either. You know, that's why this is so important, and I'll be eternally grateful to Vic for inviting me to be here, that the American Foundation for Suicide Prevention's commitment to elevating community-based programs through its Health Equity Initiative is very critical, especially today. When we amplify programs that were created with communities and not just for them by someone that may not even be a member of that community, we make visible those innovations that are already working in trusted spaces. We need to fund, scale, and sustain them. You know, for many years, if you've heard me speak before, my passion is building this national infrastructure for behavioral health that includes language access at its foundation, not as an afterthought. And remember, I said spoken language, but also American Sign Language. We have hundreds of thousands of people in this country, and we don't have the infrastructure. We don't have the workforce. So what we need to work on is developing a workforce development program for bilingual, bicultural providers. We need to fund translation and adaptation. We don't just need to interpret something. We need to build it of these prevention materials. We need to have community engagement practices that centered in life and lived experience. And then policy, you know, where everything really happens. We need policy change that mandates culturally and linguistically appropriate services as a standard of care, not a luxury. And this is becoming very difficult. Today has been an extremely difficult year for us that are working with these populations. But that's how we dismantle the systemic exclusion, not just by opening the door, but by putting up sign that says, in your language, you're welcome here. We see you. You belong. So let me be clear. Investing in cultural, linguistic appropriate suicide prevention is not only the right thing to do morally, it is the strategic thing to do if we want to save lives. Because when someone is struggling with suicidal thoughts, they don't need bureaucracy. There was a time when we were expected to ask people documentation before we saw them. How can you do that to someone that's thinking of harming themselves? We can't. That's not moral. That's not human. These individuals, they don't need to guess whether they're going to be judged, misunderstood, or even deported if they speak up, if they share their pain, if they share their need. They need to hear in their own language and from someone they trust, I see you. You're not alone. There is help. You know, when we get that right, we don't just reduce suicide. We're building a society where everyone has the right to live, to heal, and to hope. Muchas gracias.
I'm Dr. Dana Prince, and I am an associate professor of social work at Case Western Reserve University. I am sharing about my experiences, my lived experience and my research experience doing suicide prevention research and collaborative work with LGBTQ plus youth. All of the information that I'm sharing, in my opinions, however, are my own and do not reflect the larger views of the university. So suicide is the second leading cause of death for children and youth ages 10 to 24. And that's looking nationally. But when we look at LGBTQ plus youth, the risk of suicide, including ideation and attempt, is significantly larger. And there have been several decades of research at this point to identify what are those main factors. What are the main risk factors that predict suicide increase amongst lesbian, gay, bisexual, transgender, queer, and questioning youth? And the ones that are most often those that come to the fore include caregiver or family rejection. So this is when parents or caregivers either are abusive or neglectful or kick a kid out of home because of their sexuality or their gender identity or expression. Also being targeted for other kinds of abuse and neglect from other important people in the young person's life, again, because of their sexual orientation or their gender identity or expression. And peer bullying and victimization. These kinds of experiences of interpersonal violence and victimization can cause a young person to develop a negative self-concept of themselves. We call that internalized homophobia or transphobia. And those are sort of self-hatred beliefs that I'm not good, that I don't belong, that there's something fundamentally wrong with me. And through the last decades of research and activism and scholarship, LGBTQ plus communities have pointed to the outside world around us as the source of this kind of discrimination. So in other words, there is nothing inherently wrong with being LGBTQ. The issue is with how society sees us and how society treats us based on larger biases about sexuality and gender identity and expression. This is especially important right now because our communities are in a state of crisis. We've experienced harmful changes in legislation that have limited access to life-affirming and life-saving physical, mental, and behavioral health care, both for adolescents and children, but also for adults and individuals across the life course. We are seeing critical resources being defunded. One example would be the Trevor Project's crisis hotline for LGBTQ plus youth, which was the number one source of support for young folks who were experiencing ideation or contemplating attempt. Communities have been trying to rally around our young people. LGBTQ plus communities are diverse, we are resilient, and we have been taking care of one another since time began. And so there's a real wealth of knowledge and resource within our communities and a lot of organizing and activism happening to try to sow that safety net under our young people at a time of increased crisis and lack of service and supports. The other thing I want to mention here is that the removal and cutting of funding for life-affirming care for LGBTQ plus young people is not only in healthcare or mental health care settings, it's also happening in changes in policies around our educational systems and in our schools and other normative developmental spaces where children and adolescents are supposed to be supported to question their identities, to learn about who they are in the world, to see rich and varied cultural representations of difference. And that is really a core part of belonging, seeing yourself reflected in school materials, in books. So some of the other things that we have experienced here in Ohio, as well as other places across the country, are the removal of LGBTQ plus books from our libraries, from our public libraries. The removal of the mention of LGBTQ plus people from history or social studies. And so all of these factors together create a perfect storm to increase feelings of despair, hopelessness, rejection, not fitting in, not being valued or seen, and feeling as though one's life really doesn't matter. And that is incredibly troubling for many of us, for those of us who are parents of LGBTQ plus youth, for those of us who are in the community ourselves, and who work with young people in general across all contexts. Because being LGBTQ exists everywhere, and there's an intersectional component to this as well. It's not just one identity factor. You know, adolescents and young people are exploring themselves, understanding their identities in the world as a multifaceted individual, as potentially as an immigrant, an LGBT person, as a Black youth, and also as an LGBT person. And those kinds of intersections are also so important for individuals to feel themselves represented in their own home cultures, in their own places, in their own families, in their own cultural institutions, in their own religious institutions, and so forth. So we have right now a time where our communities are increasingly being targeted, and lack of resources are being pulled away. Legislation is changing access to a lot of different kinds of supports and services. And it's a critical moment. It's a powerful thing to have been asked to participate in this health equity webinar. I am honored to be here to represent my communities. And as an individual who came out 30 years ago, I have had a lot of experience with understanding the mental health impacts of societal discrimination against LGBTQ plus people on our health and our well-being. But I also have experiences of resilience, and I know the strength of our communities and the coalitions that we can build. So given where we are in terms of defunding of core crisis hotlines for this population and other challenges we're facing, building innovative and scalable interventions in our crisis response system for LGBTQ youth is very important. And I want to highlight one of the things we're doing here in Cleveland, which is the Youth Empowerment Study. And these are the various learning collaborative partners and the funder of this particular study. So this project grew out of a collaboration with many stakeholders here in Cuyahoga County and community-based organizations and agencies and community members with lived experience, both as LGBTQ plus individuals and also lived experience with suicide and overcoming suicide. And the basic 4 components of what we're doing are seemingly simple, but have a lot of complexity inside of each one. So the first thing that we're doing is that we're working with our juvenile court system here to screen youth who come through at intake. We ask them questions about LGBTQ plus identities, and they also are screened for suicide risk. We're doing the same thing within Frontline Service, which is the largest provider of crisis response and behavioral health care services for our county. If a young person identifies as at risk of suicide, meeting certain thresholds, and they also are self-identifying as LGBTQ plus, then we are going to refer them to services and peer support specialist services embedded within Frontline Service. And the whole purpose of the peer support specialist service is to have a cohort of trained young people who can relate to the youth who are experiencing suicidality and who can work alongside them, walk alongside them in their journey. We do not know of any other peer support specialist intervention like this that is being developed from the ground up, using qualitative and participatory action research methods to write stories and gain insights into the lived experiences of these LGBT youth, and then training them to be peer supporters of other youth. This concept of peer support specialist is not a new concept, but it is one that is underutilized and under-resourced. And it has a lot of promise in our local context, where we have a significant increase in behavioral and mental health problems among children and adolescents. And we have a significant shortage of trained clinicians. And peer support specialists are part of the workforce in terms of to be a peer support specialist for adolescents. You're between the ages of 18 and 30. And Ohio does have a certified peer support specialist kind of arm of the workforce. And so if we can build up that workforce, it capitalizes on lived experience. It brings people into a professional role that has the possibility to maybe be a launching pad for further education for them. And it is developmentally appropriate and impactful for LGBT youth to be paired with other LGBT youth who have walked this walk just a little bit ahead of them down the road and can help them navigate the different kinds of barriers and emotions and things that they may be experiencing that are increasing their suicidality. Here in Cuyahoga County, we have developed a vision and a mission that we are implementing through the development of our youth empowerment study to prevent suicide among LGBTQ+ youth, particularly those who are involved in public systems, including juvenile court, children and family services, homelessness services, and community-based behavioral and mental health. We envision a future where suicide among LGBTQ+ youth is eradicated, fostering hope through affirming and community-based connections that empower youth, build resilience, and ensure comprehensive support. And our mission is to build an equitable and affirming crisis response system for LGBTQ+ youth in public systems by integrating peer support specialist services to prevent suicide and enhance well-being through innovative, scalable interventions.
Hello, everyone. My name is Jeff Winton, and I am the founder and the chairman of Rural Minds. Rural Minds is the only nonprofit organization focused on mental health equity for the 46 million people who live in rural America. This represents 14% of our population. Rural Minds is a result of my nephew's suicide several years ago. My nephew Brooks, like many people in my family, including me, are dairy farmers. I'm talking to you actually from my dairy farm on Lake Erie in Chautauqua County, New York. And I wish you could see what I'm looking at, because the cattle here on our farm are outside on a beautiful autumn day here, lounging before it's time to go into the barn at night. And many people have an unrealistic idea of what life is like in rural America because of scenes like I'm looking at right now. Life in rural America certainly can be very therapeutic. It can be very bucolic and very peaceful. But underneath that facade is a lot of challenges that many people who don't live in rural America are not aware of, especially during times like we're living in right now. People in rural America are currently under a great deal of stress due to many actions that have taken place in our government. The tariffs are having a direct impact on farm families like myself, not only selling our products to other countries, but importing farm equipment and fertilizer and other things that are important in farming operations. Immigration is a huge issue that we are focused on right now. The fact remains, within the last 4 months, we have lost 155,000 farm workers in this country. Farm workers that farms like mine rely on to help milk our cows, to feed our horses, to pick our grapes, and many of the other things that the foreign guest workers provide to agriculture. Even before many of these things took place, farmers such as myself were 3.5 times more likely to die by suicide than any other occupation. Adults who live in rural America are 50% more likely to die by suicide than those who live in urban areas. But a very shocking statistic that we're working diligently on right now at Rural Minds is what's happening with our youth in rural America. The latest statistic released by the CDC shows that young people, such as my family, who grow up in rural America, are 74% more likely to die by suicide than their urban counterparts. This is a tragedy, this is heartbreaking, and something that has to be addressed, or we will lose the next generation of rural Americans. The fact remains, rural America is responsible for the food and fiber that this country enjoys. Any of you who had a meal this morning, any of you who are wearing warm and comfortable clothing, are beneficiaries of the end product of the business that I represent and that Rural Minds represents. The other thing that's very important to understand, while I've talked quite a bit about farming, is that rural America is quite heterogeneous. It is reflective of many different types of industries and occupations. Farming is one, but mining is another. The forestry industry is yet another. Fishing is yet another. We also represent the indigenous people, the Amish people, and many others who are found in rural America. And I've already mentioned the immigration issue that we're having. So we are now working diligently to represent the mental health and mental well-being of the immigrant families that are found throughout rural areas in this country. There are many challenges that people in rural America, such as my family, experience that are unique to people that live in small towns. First of all, we already have very limited resources from a healthcare standpoint, especially in mental health. 65% of the counties in rural America have no psychiatrists. And so many people say, well, why don't you just rely on telehealth? And certainly telehealth helped many people, especially during times of COVID. But the fact remains, 30% of the families in rural America have no broadband service. They have no internet. It's not because they can't afford it, it's just not available. So telehealth even isn't the panacea that many people think it is. When we launched our organization only 4 years ago, I decided I needed to move back to rural America. I needed to move back to this dairy farm where I'm talking to you today from. And after having lived in many cities and suburbs up until 4 years ago, I can tell you that when I moved back here, I now experience all the challenges and all of the issues that people in rural America face. For example, I waited 8 months to get into a primary care physician. We do not even have ample primary care physicians in rural America. And with some of the changes that are being talked about with Medicaid cuts, I can tell you that that will add an incredible burden on a healthcare system in rural America that is already extremely fragile. For example, every single hospital in the county I'm talking to you from will likely be closed. We will then be driving to Cleveland, Ohio, to Buffalo, New York, to Pittsburgh, Pennsylvania, all which are at least an hour and a half to 2 hours away. Now, I can do that doing what I do for a living, but many people that live and work in rural America have the kind of occupations that I've already talked about that makes it impossible for them to just pick up during the day and drive 4 to 6 hours round trip to go to a doctor's appointment. That just isn't possible. We also have an insurance issue in rural America. Many people in rural America, including even some of my own family members who are farmers, either have no insurance or they are underinsured. And so if they are living with both depression and diabetes, for example, they may have to make a decision between having their depression treated or their diabetes treated. No one in the United States of America in the year 2025 should be making these kinds of sacrifices. So we were founded 4 years ago, again, after my nephew's suicide, because it became very apparent that we have this escalating issue in rural America. And despite a lot of the wonderful work that's been done by many other organizations, the people that we represent can be a bit suspicious at times from people that aren't like them, from people that are coming in from cities or suburbs. And so we felt that there was a need, and certainly the last 4 years has borne that out, to have an organization that looks like the people we represent, that lives like the people we represent, and hence the reason that we're based here, our national headquarters, at my farm. I travel around the country and have the privilege of meeting many people that are in rural America. And the stories are heartbreaking. The stories are tragic. And we have stigma to thank for part of that. Because unlike urban areas where people tend to talk a little more openly now about mental health and suicide ideation, in rural America, it's still considered a character flaw. It's not considered an illness. And so a big part of our work has been focused on storytelling. I always tell the story of my family and what we've gone through, but it's critical that people start to look at this as an illness, because our premise is that people will begin to consider this an illness, which obviously you all know it is, then they are more likely to seek help and get the help that is available. It may not be as bountiful as it is in urban areas, but help is available. But first, a person has to admit and be known that there are resources that can be made available to them. I would ask you all to go to our website, which is ruralminds.org, and you will find many of the resources that we have aggregated over the last 4 years since we were launched. I'd like to thank AFSP for inviting me, and certainly appreciate the fact that as we look at mental health equity, that we're considering geographic ramifications in addition to demographic applications. Thank you very much.
All right, so thank you all so much for your presentations and for sharing your lived experiences. Each of your stories were so powerful, and I thank you for sharing a part of yourself with the audiences today. And Mr. Winton, you made a great transition into our talk, because we are focused on health equity, and health equity is not just demographic. And so thank you for bringing those factors into play. And so what you all have highlighted are the barriers and the needs that we're facing with specific populations. So Dr. Mancini, you did a great job with cultural and linguistic barriers and access to care and needs for populations, particularly immigrant populations. Dr. Prince, you did a great job with LGBTQ and highlighting some of the issues regarding belonging and making sure these populations, particularly in times of change, are feeling as if they belong. And Mr. Winton, you powerfully highlighted for us rural America and the needs that are happening within this heterogeneous population. And so thanks for bringing that home. So we know AFSP is focused not only on saving lives, but also bringing hope to those individuals who are affected. And so when you think about your specific populations, how is the work that you're doing bringing hope?
I love that question because building hope is one of the core values, right, that we have, I think that all of us share. And all of us are also representing our communities and probably have our own stories of fostering hope inside of ourselves to continue to do the work that we do in the world. I think peer support in and of itself is one of the most profound ways to build hope. And there's evidence behind that, and there's lived experience and anecdotes behind that. But what we're doing, like Jeff mentioned, the storytelling, having communities come together and having peers with lived experiences that are shared come together and hear one another's stories. And the role that a peer supporter can play in that is about sharing the story, but also understanding how to share it in a way that amplifies and elevates those components of resilience, of overcoming, of connection building, and highlights and hits on those factors that we know are protective and that we know are going to move youth into a different trajectory. So hope is one, belonging in community is a huge one that cuts across all different kinds of intersectional identity groups, and the intergenerational component as well. Having elders, having queer and trans elders tell their stories to young people, and that youth can see someone who's lived this life longer and has attained things and succeeded in things. And we know the importance of that for youth development, for all youth. All youth need that. And those that are multiply marginalized have specific need around that.
Does anyone else want to answer that question?
Yes, I also love that question. To me, equity is have given people the opportunity to access, the opportunity to have what they need to live the best life that they can live. There's nothing more than we can ask about that. And I'll tell you a story, since Dr. Prince talked about storytelling. In the adolescent clubhouse that we had, it was a culturally and linguistically relevant adolescent clubhouse where we helped young people, 13 to 17, who were beginning to get in trouble at school academically, were beginning to be recruited by gangs, were beginning to have their brushes with juvenile justice. And we would bring them to the clubhouse after school. We would, give them a snack and help them with their homework. That was the first thing. And then we would go on to provide to them alternatives. Many of them they had no one to go home to at 3:30. They had gotten to an educational level that was greater than their parents. So no one could help them with homework at home. They were being discriminated at school because of the color of their skin or their accent or any number of things. So we started developing these young people, and the results just were more than we ever expected. We had 100% graduation from high school. We had a 50% going to college, 50% going to work. We had a 78% reduction in juvenile justice relation. So to me, when you talk about hope, is to give a family that works so hard to come to the United States to give their kids an opportunity to have a better life, but only to be faced with these issues that impact their mental health, that impact their ability to cut themselves, harm themselves, or even think about or attempt or even complete suicide. So for us to be able to create this kind of program in a community that desperately needed it, with the help of the community, was the hope that that community had. And they knew the results and they saw the results that were being provided. And to me, that's what it's all about, is giving people the opportunity to access these services.
Thank you so much for those responses. And so what I'm hearing is the co-development, the fostering of the hope with the community, the individuals who are impacted, and then also giving them opportunities to really immerse more in the culture and the promotive and protective factors that exist. And so each of you have really interesting programming and interventions that you've developed. When you think about your health equity efforts, and you think about what you're doing to promote health equity specifically within your roles, what are some of those lessons you've learned or some of those takeaways when it comes to promoting health equity?
Well, I'll start if I may. So as we were doing our research prior to launching Rural Minds, it became very apparent that people we represented were not going to take advantage of support groups that were in more urban areas. They didn't feel that they had much in common with people that lived in more populated areas, nor did they necessarily have time to travel to go to support groups. And we already talked about the fact that we have an issue with broadband, that telehealth doesn't necessarily work in many parts of rural America. So what we did was determine where the people we represent, the 46 million people who live in rural America, where they were already going for trusted information, what organizations they already belong to, where we could take our programming into those types of environments. And it was very interesting as we started reaching out to some of those organizations. And again, growing up in a rural area and now living in one again, I knew many of these groups because I'm already involved, but very few of them had done much on mental health or suicide because you just don't talk about it in rural America, unfortunately. Even when my nephew died by suicide, we had community members that basically told us we shouldn't necessarily talk about what killed my 28-year-old nephew, the father of 3-year-old twins at the time. And we made a determination as a family that for the sake of other farm families, we were going to talk about it, and we were going to talk about it in detail. And that's what really planted the seeds for our organization. And so as we travel around the country and talk about what our family's been through, we are going to places, whether it's a volunteer fire department or the 4-H meeting or the Future Farmers of America or whatever the organization may be in rural America, and taking our message of hope and help into that environment, because we know if they hear the message there, where they've been going in some cases for generations, they're more likely to listen to it and take action than they would if they were going someplace that was foreign to them.
Mm-hmm. I love that notion of really making sure the services are place-based and specific to the needs of the population that's being served. And so thanks again. And I want to thank you for highlighting farmers because that's oftentimes a population that's missed. And I want to thank you for your work in that area and for your leadership with that. I want to thank the audience for giving comments and questions as well. And I have a question from our audience to ask you. What is one actionable step that either organizations or individuals can take to support suicide prevention efforts for the populations that you're representing or really most invested in?
Great question. There's a very simple thing that folks can do which is to use people's preferred names and pronouns when you are talking to somebody. And if you're in a role where you work with youth, if you introduce yourself using your own pronouns, you are signaling to that young person that you have an awareness around diversity of lived experiences of sexuality and gender. And you're signaling that you might be somebody that they could come back to and talk to. So it's a very, very simple thing. And yet it can have profound impacts. In fact, we've research that documents this, that looks at youth who have had at least one adult in their life who uses their preferred pronoun, and controlling for many of those other risk factors that I talked about before, including discrimination or family rejection or unaffirming schools. It significantly reduces suicide, just using someone's name and pronoun. That's one very simple and accessible strategy that I can offer.
Thank you. I'm wondering, Dr. Mancini, do you have, Dr. Prince mentioned language, which is a great segue to your area.
Great.
Any tips?
Great segue. So, when I've reframed how I talk about what I do. So I didn't start a clinic. I didn't start a program. I started a mission. I started a movement. And what I do is when I talk all over the country and recently the last couple of years globally, because this is a global issue, linguistic access is a global issue. I tell people that we must be determined to succeed, even with all the barriers that continue to be placed in front of us. Financial, political, individuals at the local, state, federal level. Even with all those barriers, we must stay in mission. Once you have a mission to save lives, you're going to find the support that you need. We just need to keep knocking on doors. When I first started, I knocked on every single door that I knew, and nobody wanted to help because nobody had done it before. They said, we don't have any background that this works. And to me, it was simple. You treat people in their own language, they're going to understand it better. They're going to be able to do what you're asking them to do, to live this great life that they can live. So my advice, my practical advice, is for people to do three things. First, we need to find our voice. We all have a voice, but we often don't find it. We don't know where it is. So we have to find our voice. What's the message? What is it that I want people to know and to do? The second is we need to learn how to use our voice. We can have the biggest, ugliest disagreement, but we can be respectful and we can focus on the issue. When we focus on personalities or character defects or something else, we lose the meaning of the argument. So we need to learn how to use our voice. I want the person that I'm speaking with to walk away understanding my point of view, not just walk away saying, I don't know what I'm talking about. And the third one, which is the most difficult one, once you find your voice, once you learn how to use your voice, we need to use our voice. And that's the hardest one. I've been in front of governors and my hands are sweaty. My body gets tense, but I know that I'm the person in that room that needs to help this individual understand this issue. So I know I have to stand up no matter how uncomfortable I am. And I need to use my voice because about 15 years ago, I had the last drive home when I was kicking myself saying, I wish I would have said something.
I love that. That's beautiful. Those comments really resonate well. And so thank you for sharing those with our audience. I do have another question that came in specifically for Mr. Winton. You mentioned very briefly some of the collaborations that you have with the work, and thinking about you're working with 46 million Americans, 15% of the population is who you're hoping to impact. Can you talk about building collaborations and the importance of building community as you're doing this work and how you're doing that for such a vast mission that you have?
Well, it's a great question. To start with, rural America, by definition, is all about community. So that's why we have worked diligently to determine who the community leaders are in various rural areas, and again, where people are going for this trusted information. One thing that we have utilized, which many people find interesting and hard to believe actually, is rural-based media. There is a whole ecosystem of media that reaches people in rural America. People in rural America are not watching CNN or Fox News. They are watching RFD TV, and they are listening to farm radio and reading papers like the Lancaster Farming. So we are reaching the people that we advocate for by going where they are, by meeting them where they're at, and using the media that is so critically important in their daily lives. Now, we do a lot of work with more mass media as well, because we feel it's important for the general population to be sensitized as to some of the challenges that the rural Americans are facing, especially right now. I was just in Washington the last 2 days and had the opportunity to meet a lot of people who knew very little about rural America. And once you tell them about some of the unique challenges that we are facing, you can see the light bulb go on, and it immediately makes sense that some things that maybe they're doing in more urban or suburban areas can be tailor-made to those communities. So in rural America, as I said, it's a very heterogeneous area. The fishing area of the Pacific Northwest is much different than the soybean farms of Iowa, which are different than the indigenous parts of New York. So we are tailor-making our programming and our messaging to reflect the people in that particular area of rural America, because we know that's the only way that this will resonate and make sense to them.
Thank you so much. And thanks for educating our audience about rural America as you're telling us more about how you're helping. So thanks for that. So our panel is wrapping up. I hate that this is coming to an end. Such a rich, encouraging conversation. And I want to see if we can get one final closing thought from each of our speakers today. We'll start with Dr. Mancini.
Thank you so much, Dr. Richardson. I really appreciate the opportunity to do this. And thank you to AFSP and to everyone that put this together. You know, as we bring this conversation to a close, I want to leave you with the same truth. Language and culture are not side notes in suicide prevention. They are the very foundation of it. I've read suicide prevention plans that acknowledge that culture and language exist in that region or that state, but there's absolutely nothing in the same document to address it. If you cannot find help in your own language, and if you're deaf or hard of hearing, you cannot find help from a licensed therapist who knows American Sign Language. In these settings that honor values that the system has failed to reach, and they're not included in the first place. We need to be able to have that individual find help in the way they can understand it, so they're able to take the steps needed to lead a successful life. Thank you.
Thank you, Dr. Prince.
Yeah. What I want to say right now to the LGBTQ plus community is that you are not alone, that you are loved, that people, all kinds of people, want to see you alive and thriving, and we will not be erased, and we will not be silenced. And I want our young people to know that we want them to live and we want them to flourish. If you are somebody who has a relationship with young people, if you're a coach or a teacher or a pastor or a rabbi or a parent, please try to incorporate some way of sharing your openness around sexuality and gender as diverse and beautiful, that all genders and all sexualities are normal and healthy and belong. I think being able to share more of those messages inside of the communities that you are in can make a huge difference, more than you may ever know.
Thank you so much. And Mr. Winton.
Yes. So to my fellow rural Americans, I would say we see you, we hear you, we are you. We are here to serve you and to advocate for the unique challenges that are faced in small towns across this country. I think all too often, because people in rural America are so spread out, they aren't always as visible as people that might live in cities and suburban areas. But we need you. You are providing incredibly important commodities that our daily lives depend on. And while we know this is an incredibly difficult time for you right now, we are fighting as hard as we can, and we will ensure that policymakers and other people who control a great deal of what happens in this country do not forget about you, that they remember you when they're having important conversations about mental health and suicide.
Thank you to each of our speakers for your comments today, for your wisdom. And I just want to say to AFSP, as well as to our speakers, we see you, we honor you, and we thank you for the work that each of you are doing to keep communities uplifted and to work together with communities to make life better and restore hope. Thanks again to AFSP for this opportunity to moderate this panel.
Thank you so much, Dr. Richardson, Dr. Mancini, Dr. Prince, and Mr. Winton, for such an informative discussion. Clearly, we have challenges with language access for individuals who identify as LGBTQ, and in our rural communities. Mr. Winton, as someone who was born and raised in rural North Carolina, so much of what you shared resonates with me. Oftentimes, when we mention health equity, people's minds immediately go to race and ethnicity or sexual orientation or gender identity, but we forget that our rural communities are historically marginalized. I want to thank each of you for your dedication in serving these vulnerable populations. Next, we will be sharing a video greeting from one of the most influential legislators in Washington when it comes to the matter of health equity, Congresswoman Bonnie Watson Coleman. Congresswoman Watson Coleman has served as the U.S. Representative for New Jersey's 12th Congressional District since 2015. Among her many accomplishments, Congresswoman Coleman commissioned the Congressional Black Caucus's Emergency Task Force on Black Youth Suicide and Mental Health. In December 2019, the task force released a report ringing the alarm, The Crisis of Black Youth Suicide in America, outlining the state of Black youth mental health and detailed policy recommendations for consideration by Congress. We invite you to listen to these remarks from Congresswoman Bonnie Watson Coleman.
Hello, my name is Bonnie Watson Coleman, and I represent the 12th District in New Jersey, and I am the sponsor of the Pursuing Equity in Mental Health Act. I'd like to take a moment to discuss my work on mental health policy in the hopes that it inspires you in the work that you continue to do. In 2018, I began to notice an extremely troubling trend on Facebook timeline. Repeated posts by devastated parents who had lost their young to suicide, some as young as 5 years old. I was shocked, I was heartbroken, and I was determined to take some action So my team and I set out to see if there was a real trend of increasing suicides, or if it was merely a problem with Facebook's algorithm. What we found was that while overall youth suicide had been on the decline among young Black children, it was on the rise. I brought this finding to the attention of my friend and colleague, Karen Bass, who was then the chairwoman of the Congressional Black Caucus and who is currently mayor of Los Angeles. We decided to put together the Emergency Task Force on Black Youth Suicide and Mental Health, which I was blessed to lead. The task force included 17 members of Congress, as well as a working group of 22 experts in psychiatry, psychology, education, and suicide prevention. These experts included several people that you may know, including Dr. Shirley Molick, Reverend Walrond, and now Congressman and then Assemblyman, Dr. Herb Conaway, and of course, Dr. Michael Lindsay, one of my favorite people in the whole wide world, was the leader of the working group. We spent the next several months conducting research, interviewing parents, school resource counselors, medical professionals, and students. And then, with the working group, we compiled a 38-page report called Ring the Alarm, the Crisis of Black Youth Suicide in America. Our research found that suicide was on the rise for our Black children and youth, especially the very young. The causes were varied, but a significant factor was a fundamental lack of access in Black communities to the kinds of mental health resources that other communities have. From that report, our team developed the Pursuing Equity in Mental Health Act, which would authorize $1 billion in grants and other funding to support research and to enhance the quality and accessibility of mental health care. It would include allowing funding to increase the number of minorities entering the mental health field to expand the availability of culturally competent care. I'm still fighting to pass this legislation, and earlier this year, we introduced the most up-to-date version with Senator Hirano from Hawaii. In the time since our report was first published and our bill was introduced, the situation has only become more dire. The COVID pandemic was especially difficult for folks who were already experiencing mental health struggles. The loneliness and the isolation caused by the pandemic exasperated what was already a severe problem. From 2018 to 2022, the suicide rate among Black youth ages 10 to 17 increased by 54%. And during that same time, the suicide rate among white peers in that same age group declined by 17%. Let me say that again. During the pandemic, the suicide rate among young white people went down, while the suicide rate among young Black people went up. That's staggering. It's infuriating. It is not inevitable. It is indeed preventable.
We truly thank Congresswoman Coleman for those amazing remarks. One of the things that we want to accomplish in these webinars is to showcase a community-based program, not simply to highlight the program, but to demonstrate that communities can create resources that serve their community members in suicide prevention. We will now be joined by Dr. Lena Green, who will present on today's feature program, Hope Center Harlem. At the close of Dr. Green's presentation, we will engage in Q&A. Feel free to add questions to the chat. Also, as a reminder, there will be a survey link in the chat. Please access the QR code and share your feedback. And with that said, ladies and gentlemen, Dr. Green and Hope Center Harlem.
Thank you, Victor, for that warm welcome. I appreciate being here, and thank you so much to AFSP for giving me the opportunity to share more about our programs and our services. So today, I'm going to be talking a little bit more about church-affiliated mental health services and leveraging potential to promote mental health equity. You will see another name here, and unfortunately, my colleague will not be able to join, but I look forward to sharing more about our programming, and we will certainly be able to answer as many questions as possible. So just a little bit about me. As my colleague Victor shared, I serve as the executive director of the Hope Center Harlem. I also serve as the associate professor and program manager at Mount Sinai Icahn School of Medicine, which is our programming partner and the hospital that works very closely with us and provides our psychiatry resident services here, which you will hear more about in this presentation. I also come to you sharing 25 plus years of direct clinical practice, and excited to share a little bit more about our community-based mental health services. So today we're going to be talking about why it matters. We're going to touch on racial disparities in depression care. We're going to talk about the rationale for church-affiliated services. And then I'm going to close by talking to you all more about the Hope Center model of care. So why does it matter? Well, for one, we are based in New York City, specifically in Harlem. And if we think about the landscape of mental health, we know that 1 in 5 U.S. adults experience mental health challenges each year. 1 in 6 youth across the country have a mental health condition, but only half of those receive treatment. 50% of all mental illness begins by age 14 and 75% by age 24. And we know that suicide is the second leading cause of death for adolescents across the U.S. And right here in New York City, those statistics are about 1 in 10 teenagers have either thought about or attempted suicide. When we look about the Harlem specific data, looking a little closer in our neighborhood in New York City, we know that we have higher poverty rates compared to the rest of the city. We know that underemployment and unemployment have historically been higher in places like Harlem than the average places across the country and as well as the city. We also know that we have a ton of unmet mental health needs among low-income adults in Harlem, and 1 in 3 report needing mental health services but unable to access them. We also know that reentry and justice-involved populations, especially in Harlem, is among the top across NYC neighborhoods across our city, and we know that it's a challenge that faces many people impacted by complex trauma and barriers to reintegration. So a little bit about the Hope Center. The Hope Center stands for healing. Well, Hope stands for healing, all purpose, and evolving. We were established in December of 2016, and our mission is to provide quality therapeutic services to the Harlem community and beyond, and directly impact mental health needs of our community, as well as promoting mental health and wellness. Our vision: to empower and support our community in the process of creating and sustaining lifelong wellness. So one of the things we know is that depression, according to the World Health Organization, is the #1 cause of disability worldwide. So that means that we have tons and tons of people who are suffering from a debilitating illness. So when we are looking at African Americans specifically with depression, we know that they are also more impaired. On this disability scale, African Americans were asked to rate how much their depression interfered with their functioning in work, relationships, social life, and overall well-being. And you can see here that essentially what this is saying is that African Americans rate higher and are sicker longer than their white counterparts. When we think about where people go for mental health care, this slide, according to Pew Research, shows that outside of mental health professionals, clergy, that's our faith-based leaders, are more likely to provide depression counseling more so than clinicians, general MDs, and psychiatrists. So that means that we consider our clergy as frontline workers. And I'll tell you a little bit more why that's significant. Because the Hope Center specifically is connected to First Corinthian Baptist Church, which is one of the largest congregations in New York City and most certainly in Harlem. Okay, so here we're going to take a little bit of a look at one of our videos from Pix 11 News that talks a little bit about the relationship between a psychiatrist, a pastor, and myself as the executive director.
Like many large active churches, First Corinthian Baptist has an excellent music ministry, and it has a well-respected pastor.
God sets before you a vision of possibility.
He's known for his casual style, but that's not the only unorthodox thing about Reverend Michael Walrond.
I went and found an amazing therapist that really nurtured me to a place of wholeness.
And he's talking about the psychotherapy he receives in his sermons.
If I began to speak about it freely, it would liberate others to talk about it.
I'll never forget it. Miss Betty Davis came up to me after the presentation and said, "You have to meet my pastor, because he talks from the pulpit about the importance of mental health."
Psychiatrist Dr. Sidney Hankerson was invited by Reverend Walrond to start mental health programs at First Corinthian Baptist designed to stop historical inaccuracies and atrocities in Black communities.
There's a tremendous amount of distrust that is rightly deserved in the Black community as it relates to seeking mental health care.
Early American psychiatrists like John Galt wrote that Blacks are immune to mental illness because they couldn't own property or fully participate in society. And pre-Civil War experts said that fleeing enslavement was a mental illness, treatable by whipping anyone who tried to escape.
We know that racial trauma is real.
Dr. Lena Green says that narrative is why Pastor Walrond and Dr. Hankerson created the center that she now runs.
To help people back away from the stigma and the shame around feeling like I'm crazy or I'm not doing well.
The whole center stands for Healing on Purpose and Evolving. It wasn't just for members of the church. Anyone can benefit from the programming here.
We offer 10 sessions free of charge, so no one ever has to worry about finances or insurance as a barrier to getting treatment and care.
They also have a program called Mental Health First Aid that trains regular folks to assist people with mental health challenges.
After doing the training, one of the community members, who's a member of the church, came up to me in tears and she said, "Dr. Hankerson, thank you so much for this. My granddaughter is 17 years old and she was recently diagnosed with bipolar disorder. I thought before this training today, I thought that she just was being a bad person."
Just like the Hope Center, Dr. Hankerson is based uptown, here at Mount Sinai, which is right across the street from one of the city's largest areas of public housing.
How do we engage people in barbershops and beauty salons into mental health care? One of my dreams is to replicate the Hope Center in every major city in the United States.
James Ford, Pix 11 News.
So in the video, you saw a little bit about how our services are linked between the house of worship, the church, First Corinthian Baptist Church, the Hope Center, which is a 501c3, and our connection to the hospital. And I would also add that the only correction that I would add to the video is that I'm actually not a psychiatrist. I'm actually a clinical social worker. So talking a little bit more about Black mental health, it's one that's couched in historical diversity, which includes slavery, sharecropping, and race-based exclusion from the healthcare system, the educational system, and social and economic resources. And that really translates to socioeconomic disparities that have been experienced by that population. Socioeconomic status is also linked to poor mental health outcomes, including poverty, homelessness, incarceration, which also means that folks are at higher risk for poor mental health. We also know that racism and discrimination, as well as marginalization, continues to have an impact on mental health for the African American population. We also know that negative stereotypes continue to exist, as well as stigma, and that those have adverse consequences, especially when we think about things like help-seeking behavior and the long distrust of authorities and health systems historically. So taking a closer look at houses of worship and mental health and wellness. Well, we know that the Black church has historically played a large role in communities of color. They were a safe haven for many. Clergy and faith leaders, as far as we are concerned, are frontline workers. When we look back at that slide earlier that I showed, right, we know that many people are more likely to talk to their faith leader than they are to go to the doctor to talk about any mental health systems. It's also an opportunity for us to lean in and learn to share more about mental health. And we have partnered with various organizations, including an organization called Triumph, connected to Mount Sinai Hospital, that has allowed us to provide depression and anxiety screening, as well as suicide screenings for members of the church, in addition to folks receiving mental health support or seeking mental health support and services at the Hope Center. I want to talk a little bit about the role of faith leaders. So because of the linkage that we have with the church, many folks may come in with a request for prayer, which is great. So when someone says, hey, I'm looking for prayer because I'm depressed, or I'm looking for prayer because I am experiencing domestic violence, those folks receive prayer from our faith leaders, but then they also receive a warm handoff as well as education and a referral to the Hope Center to get connected to a mental health professional who can provide additional services. We also have a number of community-based initiatives. So sorry. We also have a number of community-based initiatives. One of those is Breakfast Before Books, where we basically serve the community, specifically our youth before they go to school. We also have a food pantry. We have a partnership with an organization called Choose Healthy Life, where we focus on various health challenges like diabetes and high blood pressure. Furthermore, all of our faith leaders have been trained in mental health first aid, and we've been doing that for several years. And then many of our faith leaders, including our deacons, have also been able to obtain a certification in mental health coaching. So they really work very closely with us on those warm handoffs, and we bring them along to do education and outreach as well to the community. Okay. So when we look at the African Americans, according to Pew Research, they are one of the most religious groups in the United States. 87% of African Americans say that they belong to a religious group, and 79% say that religion is very important. In addition to that, more than 50% of the folks who took the survey also said that they attend a church service or religious-based service at least once per week. So now I want to talk to you a little bit more about the Hope Center model of care. Okay. And I love showing this slide because our mental health services are really integrated into the life of the church, which means that we've really built a culture of mental health and wellness right within the congregation where we serve, where we do outreach, and where we pull from for the services that we provide. And so this is just an example of what we call our Hope Center Sunday. And once a year, we are able to really take over the entire church service to really focus in on mental health, where we're able to provide education to the community and integrate, our mission, our vision, our values within the church service proper. So a little bit about the services at First Corinthian Baptist Church and how we even got started. And so to share, again, just going back to the story about that interconnection between mental health and faith. One of the things that we're most proud of is that the pastor of the church has been talking about mental health from the pulpit for several years. He's been transparent about his own battles with depression and anxiety, as well as suicidal ideation. He's talked very openly about discussions regarding therapy. And then we also have this notion that healers need healers, again, when we think about faith leaders being frontline workers. So we actually started with one clinician on site at the church, and that was happening for several years. And her services quickly became popular, and she quickly had a waiting list, which still continues today. Those services were available to all members of the congregation at no cost. And again, we saw an increase in need, but then we also saw that there were concerns about stigma. And we had clients increasingly requesting privacy. And what I mean by that is that folks were coming into the church to receive services, but because they were coming into the church to receive services, they were also concerned that other people would know that they were also receiving therapy there. And so it was at that point that we decided that the Hope Center would be established as a separate entity outside of the church building. And we were founded in 2016. So what are the services that we have at the Hope Center? Well, we have counseling services for both individuals and families. We provide medication management with our psychiatry residents in our partnership with Mount Sinai Hospital, Icahn School of Medicine. We have a ton of group-based counseling support services, which we'll share a little bit more. And we have those 12 free sessions of evidence-based therapy. So our clinicians focus on everything from cognitive behavioral therapy to interpersonal psychotherapy. We also have referrals for longer-term treatment and care needs. And then we also have a ton of community-based programs. And again, all of our services are free, and those are also flexible. So we offer services both in person and via teletherapy. And then two other specializations that are worth mentioning. We have partnerships with various folks who are specialized in addiction treatment and substance use. And then all of our clinicians are trained in what we call prolonged grief disorder. So a little bit about our client demographics. So who do we serve? Well, our clients, our innovators, as we call them, are ages 12 to 95. 90% of the folks that we provide services to identify as Black, 72% women, 17% LGBTQIA+, and then 27% include seniors, and 17% also include our teens. And we'll talk a little bit more about those programs and services shortly. So what are the main problems that folks are coming in and asking support for? Well, it's really focused on depression, anxiety, trauma, and grief and loss. What's not listed here is substance use. And I would say that those things certainly spiked. That request specifically for substance use and alcohol services spiked certainly during the pandemic and shortly after. But I would say when we're looking at the top 4 concerns or the top 4 challenges that people are saying are presenting problems, they're listed here. Okay. So a little bit about our staff diversity. So I hinted at it earlier, but I want to make it a little bit more plain about who is providing these services at the Hope Center. With the bulk of our staff are social workers. We also have psychiatrists and psychiatry residents. We also have several clinical psychologists. Can't say enough about our faith leaders. So our ministers and our deacons are also part of our staff diversity. Also mental health coaches, And then we have our clinical fellows who are our interns. And then we have public health students who also join us as well. So tons of folks providing services. And so here's a peek at our organizational charts, which tells you a little bit about, what we do here and how folks are provided services. Okay. So we have been working on building a pipeline to advance mental health clinicians in this field. We take that job quite seriously. So we serve as a field practicum site and have a partnership with several universities across the country. So the majority of our students come from New York City master's level social work programs. But we also have students who come to us from Louisiana State University. We have Howard University, which is our first HBCU collaboration, as well as Rutgers. And then we also have a partnership with Manhattan University where those students are getting a master's in mental health counseling. With regard to our psychiatry and our psychiatry residents, we are focused on training community-based mental health clinicians. And so we are providing our medication management and mental health counseling services through our PGY4s as an elective in partnership with Mount Sinai Hospital. And that program began in July of 2023. That program has also grown over the past couple of years, and we're proud to say that we now have 3 psychiatry residents providing services here at the Hope Center, and we have 4 supervising attendings. So one of the things we haven't talked about just yet, but you've heard me mention it, is innovator. And so one of the things that's really important to us is our language. And so we don't call the people here who are receiving services patient. We don't call them a client. We don't call them a sufferer or a victim. We call them an innovator. And what is an innovator, you might ask? Well, it's one who makes healing a lifestyle. It means that you are courageously engaging the pain points of your current narrative to transform your wounds into wellness. And so we try to use language here that is approachable and friendly because we know that stigma still has a huge barrier when it comes to seeking services and care. So I want to touch base a little bit about our teen programming because that is where we do the bulk of our suicide prevention services. So we began addressing the crisis of youth suicide, specifically among Black and Latino youth during the pandemic. Unfortunately, we were receiving tons and tons of calls and requests for services, and we kept having to refer them out. Why? Because initially, we were only providing services to adults 18 and over. And those calls just kept coming and would not stop. We were getting calls from parents, from grandparents, from teachers, from mentors, and with really no place else to go, but highly concerned about the mental health state of the youth in their lives as guardians and parents. And we had several teens who had suicide attempts. And so we decided that we were going to step in and fill the gap and do something during that time. Proud to say that we were also featured in NPR this past year. We can share more about that article. But really, the article in NPR really talked about how the Hope Center, connected to a Black church, is really addressing and tackling suicide for our adolescents. And we have several of those programs that are operating now. We have one program that focuses on photography, which we'll learn about in a second. And then we want to take a moment to share a little bit about our star program called Thrive, which is where the bulk of our suicide prevention services are focused. And you're going to see a little short video and hear more from our children and our youth and our teens about their experience in our program.
My name is Kennedy. My name is Jessie, and we thrive.
My name is Ziggy, and I thrive.
I'm Casey. I'm Kylie.
And we thrive. My name is Josiah, and I thrive.
Yay! Thrive shirt on.
Thrive program means to me that you have like other people that goes through the same thing as you, but you don't say anything, but we could come together as a group so we all could talk about it.
The Thrive program is a program that helps young people and teenagers with mental health. It serves as a way to have a stress-free life. They tell you how to function with other people. They tell you how to have a better social life. So I think that's really good.
The Thrive program means to have fun, to respect, love, and accept each other. I've had a great time so far. I've made new friends. I've made new counselors and staff that care about all of us. And I made new friendships.
The Thrive program to me means to try to be open-minded, not all the time, but most of the time. Try new experiences, and I got to meet new people. I've made a lot of friends, and I really like the counselors.
I think mental health is important for Black and brown teens like myself because I feel like as Black people and as a teen, a Black boy, it's harder for me to do certain things that other people can do. And I feel like I need to have that mindset to know that I have to be better because I need to show other people who are either younger than me or just know less than I do that the way we have to think and move as a Black and brown teen.
Like recently, a lot of kids have really died lately, and they were mainly African Americans. And some of the kids were dying because of mental health or gun violence. So with mental health, people are dying from mental health because they didn't have a person around to talk to. And when they don't have somebody to talk to, they just think about dying because that's the only thing that comes to their head. That's why I'm thankful for my mom for putting me in this program so I could talk to people about my feelings. But yeah, I have a wonderful mom, a wonderful dad, a wonderful grandparents, a wonderful family system to talk to. But I feel like Thrive was just an extra booster for me to let go of my feelings.
Somebody my age, like just teens in general, should join Thrive because it teaches them a lot about Black history. It's a way for them to like communicate with somebody, even if they're like, they don't want to tell someone or something like that, they could like vent to Thrive.
I feel like they should join Thrive mainly because, first off, I wasn't really worried about mental health before this. And then after I joined Thrive, I started taking care of my mental health a lot more because they're helping me see that mental health and physical health, they can both take a toll on you no matter what. So I'd say you should join it because it does help you kind of take a load of stress off your shoulders, stops you from having so many burdens. Now I can't say that it's gonna help everyone, but it helps me, so it might help you too.
We are Thrive!
Yay.
And cut. I have to cut the video because of it.
Okay. So you heard a few stories from our young people. But, to share a little bit more about that program, we started that program initially with a grant from Nike, and we're so grateful for that opportunity. Many of our youth are involved in sports, and our athletes in various sports. And so this was in addition to what they were getting. I'm sorry, I'm going to start that over. Okay. Okay. So you had an opportunity to hear a little bit from our young people directly about their experience in our Thrive program. But just to share a little bit more about how this program got started, our suicide prevention program initially was started with funding from Nike. So we're forever grateful for us to be able to start that program, especially right after the pandemic. And we've been continuing that program. So the program started weekly. And now we're doing the Thrive program on a monthly basis. And on average, we have about 20 youth that come to us for this program. We also very openly talk about mental health. We talk about suicide. We talk about resources. We talk about who our trusted people are in our lives. We talk about help-seeking behavior. We talk about social media and its impact. And then we also do quite a bit around social and emotional learning. And then you heard me talk a little bit about some of our other team programs, our Snapshot program, which focuses on photography. And then we do a host of facilitated partnerships, with varying clinicians who come in and serve as guest presenters or guest lecturers to our teams. And our last guest lecturer was Dr. Omar Keels. And we did a little bit of a remix around mental health, focusing on the historical series of A Different World. And so that was a lot of fun. Okay, so a little bit about our numbers and our impact. The Hope Center has provided over 1,500 individual counseling services, so direct services, to over 1,500 folks. I'm going to start that part over because I said it twice and that was not necessary. Okay. Now, so a little bit about our numbers. So since our inception at the Hope Center, we have provided services, direct services of counseling, that is, to over 1,500 innovators. We've hosted over 126 groups. And then we've provided services to over 16,000 individuals for our signature events. We also have a unique crisis text line where folks can also receive services. And so we continue that partnership that has been in place for the past 7 years. In 2024 alone, we provided services to over 150 people, as well as 33 groups. And we're so proud that our services are reaching across the waters. And so folks are coming to us most likely for our virtual groups and joining virtually from places like Canada, India, the United Kingdom, and Brazil, to name a few. And then in 2025, we hosted our first men's only grief group. And so one of the things that we're most proud of is that we are checking in with the folks who are receiving services to ask, what else can we do? How else can we be more impactful? And how else should we be serving you? So that community feedback is important. Here are just a few examples of the kinds of programs that we do. So you can see that we have our senior chair yoga that happens on a weekly basis. It's one of our more popular groups. We have our Pride series of events that we do every year during June, Pride Month. Again, we focus on healing conversations, focusing in on suicide, substance use, and mental health for men. And then we also have things like our resource roundtable, where we invite the community in to talk a little bit more about the kinds of resources that they need, and for us to be able to partner with various organizations across our community. Just a few more things that we do here: our Savvy Seniors group, and our mindfulness-based stress reduction, to name a few. Okay, so what do we know based on all of this? Well, we know that the demand for our services outweighs our capacity. We know that many of our clients need longer-term treatment. We know that access to additional resources are critical, such as case management, housing, employment, education, and that we know that we are seeing a decrease in symptoms. Currently, unfortunately, we have a waiting list of over 250 people, which means that we're doing something right, because the word is getting out and folks are coming to a trusted entity to receive services. But unfortunately, we just don't have the capacity to be able to see all of those folks, which means that people have to wait longer for care. So a few highlights of how our impact matters. Well, we provide culturally inclusive care. We provide access to high quality evidence-based treatment and interventions. We are a trusted community entity. We know that there's historical mistrust of institutions, and that we continue to see high rates of depression, anxiety, grief, and attempts at suicide. But we know that we're providing a much needed service that is free. We are also providing additional access to services and referrals for insurance, for social services, for medication management. And we're seeing an increase in requests for services, specifically from our men, our seniors, our LGBTQIA+, as well as our teens. We currently are in the process of overhauling our data evaluation, and we have a strong partnership with NYU McSilver Institute for Research in Poverty. We are currently in phase 2 of looking at our outcomes, looking at mental health symptoms improvements, linkages to community resources, and successful connections to ongoing services that we are referring out for. So here are a few examples of our funders. We are proud recipients of funding from the Mother Cabrini Foundation, from the TJX Foundation, from Nike, which you heard me mention earlier, from Mount Sinai, from the American Psychiatric Association Foundation, as well as APA, Charles Schwab, as well as the Scarlet Feather Foundation, to name a few. Here are a few Hope Center testimonials. I'll leave that up for a moment so that you can take a peek at that. And again, happy to share. And you can also find those Hope Center testimonials on our website at hopecenterharlem.org. So just wrapping it all up in our last few slides, our main goals are to, 1, deliver culturally sensitive care in a trusted setting. All of our services are evidence-based and free of charge to NYC residents. We work from a strengths-based approach, and we are flexible in our service delivery. So I talked a little bit about that, both in person and teletherapy. Our second goal really is to equip our clinicians in the faith-based model of community engagement. And that is around forming strong partnerships, assessing the community's needs, identifying leaders who will support, those are our credible messengers, taking the time to set the context, and of course, honoring our community's culture. Right, so through our strong partnerships with Sinai, through our universities and colleges, and through the church, we really are focusing on recruiting and training clinicians of color, clinicians who are interested in community-based mental health care, and also clinicians who are interested in integrating faith and spirituality within mental health. And last but not least, increasing access to mental health care services and promoting equity. We have a firm belief and culturally inclusive mental health services that are desperately needed in communities of color. We have also developed and tested strategies that significantly increases participation in populations and communities of color in mental health programming. Again, those flexible services. We honor work schedules and those work hours for folks who can't make it during the regular 9 to 5. We're using marketing materials that are racially concordant with targeting the population that we're looking to serve. And we're using trusted, credible messengers to increase the awareness of our services. And we're framing our program as an issue focused on social justice. So in summary, we are certainly looking to scale up our services. We are very much interested in building networks of hope. And again, to deliver culturally sensitive care in a trusted setting, equip our clinicians in the faith-based model of community engagement and care, and increasing access to mental health services to promote health equity. All right. So I want to leave this with all of you, right, that when you think about partnerships or where places where folks are receiving care and services, that also churches and church partnerships are ideally suited to promote mental health equity. We note that community-partnered engagement helps to foster and expand novel church and academic-based partnerships, and partnering with community-based participatory research allows the Hope Center to build its research capacity. And so those partnerships with academic institutions and hospitals helps us to get further and closer to the goal. And so here's just a little diagram and example of what community partner participatory research looks like. So we're looking at planning, empowerment, participation, trust, and capacity to decrease those disparities. And with that, I want to say thank you for your time. I've mentioned my colleagues here several times, and so their information is here. So thank you to AFSP. Thank you to Pastor Mark Wallen, who is our partner at the church. And thank you again to Dr. Sydney Hankerson, who is our inaugural medical director and vice chair of psychiatry over at Mount Sinai Hospital. So thank you.
Dr. Green, thank you so much for sharing on your program. It was just amazing to hear about all the incredible things you're doing. I had an opportunity several months ago to come and visit your program and take the tour, and I still was blown away listening to you talk about all the different the different moving parts of your program. It is extremely impressive. I will tell you this, as a preacher's kid myself, as I'm listening to you and reflecting on all the things that we didn't talk about in the church when I was growing up, and all the things I never heard, and even the disparaging things I heard that fed into stigma. As I'm listening to you talk about your program, one of the first things that comes to mind is that this is what faith-based communities and houses of faith should be doing. Because what you're doing is you're treating the whole person. And so that part is so impressive. You talked about the genesis of the program and a little bit about Pastor Warren's vision. I'm interested in hearing from you, though, as a social worker, what drew you into this project? Were you already a member of the church? How did you get involved with this?
Yeah, great question. Thank you for that. So I was already a member of the church. So I've been a member of the church since 2006. And since that time, I had been working in leadership with actually the young adult ministry as well as the youth ministry. And then when the Hope Center first opened, certainly lent my services. I was available for any consultation and things like that. But even prior to that, when we had the first mental health clinician inside of the church, we would just touch base and talk a little bit about like what was going on, the kinds of cases that she was seeing, giving some feedback. And again, saying I'm available to support in any way, shape, or form. And then also putting her in touch with other mental health clinicians who were right inside of the church. So whether they were social workers or psychiatrists or folks who were focusing on substance use, I feel like we had quite a community already inside of the church to support whatever was going on.
Yeah.
And so I actually was asked to come and run the program during the pandemic. And at that time, I was actually working for city government. I've been in city government for 20 years. And I was serving as the deputy director for the Office of Substance Use Policy and Planning at the Department of Social Services. And so, also being a Harlem resident and a member of that faith community, just seeing how we were just hard hit here in New York City during the pandemic, and just seeing, the rising challenges and needs specifically around mental health really tugged on my heart. So.
Well, I love your approach, and so much of the approach of Hope Center Harlem also aligns with the way that we approach our work here at AFSP, in that the way you frame access, it's so important that we think differently about access. We often think about access as being just putting more of the same old traditional resources in physical proximity to people and communities.
Yeah.
But it's so much more than that. It's about having access to resources that are culturally relevant.
That's right.
Resources that are relatable to the lived experiences of the community that you're trying to serve. And maybe the most important thing is resources that a community is going to be willing to access. And you've tapped in to all of that. One of the things I love also about the way you are approaching this is that you are identifying faith leaders and people in the church as frontline workers. And I love that, the way that you frame that, because I think oftentimes for communities of color often don't enter into the mental health system until they're in crisis.
Absolutely.
And so they are introduced to the system in the back of a police car or in an acute care emergency department. But oftentimes the first people to have access to them will be those faith leaders. So I love that approach, that frontline worker approach. Can you talk a little bit about that concept of thinking about them? And do they think of themselves as frontline workers?
Yeah, so I'll start with the do they think of themselves as frontline workers? And I would say initially they did not, right? And so it was us coming in to talk to them about the existing knowledge that they had, but also the limitations that they had, right? And also, sort of calling out the fact that, you don't have to pretend to know it all, and that there are professionals, trained professionals who can actually do this work and support you, but work alongside you, right? That everyone has their own area of expertise. But also recognizing the fatigue that they also experience as faith leaders with their own levels of stress, with their own levels of mental health, and how we could sort of undergird them as a partner in this journey for mental health for their congregants. And I think, having a faith leader who bought into that, but also who was clear about that for himself, made the task a little bit easier. And I think when you have a strong faith leader, you have someone from the pulpit sharing those messages, then you have people who are more susceptible to those kinds of messages and hearing those experiences because they've seen him model it for himself.
Yeah, that's fantastic.
So that was one thing. And then the other thing that we had to sort of think through was like, okay, so if folks are not going to say yes, right, I'm going to come in with pom-poms in specifically for therapy because I've been raised to just pray it away, right? Mm-hmm. How else could we reach them? And so I like to say that we're a little creative about how to get people in for the services. So if we can, offer something like planting for wellness and talking about, hey, we have this community garden in the back. Let's talk about using some of our herbs for a healthy meal and talking about how healthy meals can contribute to a healthy mind and a healthy lifestyle. And that those are being taught by mental health clinicians in partnership with a chef. Right?
Yeah.
Seeing a mental health clinician talk about healthy eating or how your diet impacts your overall well-being, then they're more likely to come in for additional services. Mm-hmm. Or if we can do it in a group-based setting, which works for several reasons. One, you get to be in a space with your peers. But then it also allows us to provide services to a large group of people at a time as well, right? Mm-hmm. Because we have such a long waiting list. But, we're asking them, well, what do you want to hear more about? And so they're like, well, I've never tried mindfulness-based stress reduction, but if it can help me reduce my stress, I'm willing to try it. Yeah. Right. Yeah. Our senior chair yoga at this point is like packed to capacity. Right. So never have we had. And these are folks who are like 65 and older. Mm-hmm. So they're coming in and so they're doing, they're able to stretch. They're able to pray, but they're also able to do some meditation and some mindfulness as well. And for some of them, this is the first time that they've been exposed to a mental health clinician.
Yeah. That's the thing I think that that strikes me, because I know when I have conversations, and oftentimes they're conversations with faith-based groups, but when I'm having conversations with Black and Brown communities, it is oftentimes the first time they've ever had a conversation about mental health, and especially if I'm talking about suicide, it's the first time they've had that conversation, at least collectively. And if they have had a conversation in the past, it's usually a conversation around, you don't need to see a clinician, you don't need to see a mental health professional, you just need to pray more, you need more faith. Now, to that point, for a lot of people, when they hear about this program at Hope Center Harlem, their mind is going to immediately go to, this is a religious program. But it's not. It is a clinically sound program based in a faith-based space, but it's not really a religious program. It takes into account faith, because that's a part of the life of the people that you're serving. And so faith is relevant to them. Faith is important to them.
Absolutely.
But so much of this it really is packaging clinically sound mental health practices, but presenting them to people in a way that they're willing and able to receive them. And I think that is just amazing.
Absolutely. Thank you. And when we think about the statistics, right, those high numbers of folks who are, who do, believe in a faith, who do believe in spirituality, who are connected to a faith-based institution. Those are many people who are waiting to receive services, right? So whether they're mental health services or other health services related to heart disease or diabetes or any of those things, right? It's the perfect setting, because otherwise they would not receive the information or the services or the intervention at all.
Yeah.
Right?
Yeah.
So we're just tapping into what is, an audience that is already there,
right?
But we're also teaching them, and we're sort of like dosing the information, right? So if I'm allowed to get up every Sunday and say, hi, I'm Dr. Lena Green. I've worked in ministry here for many, many years, right? People know me. I'm also someone who looks like them as well, right? I'm also someone who worships in the same space, but I'm also coming and saying, hey, I'm a mental health professional, and here's what I'd like to offer you. They're more likely to come and talk to me, right? And I'm not saying I'm going to prescribe anything. I'm not going to put you in any program. I'm just inviting you to have a conversation with me about, what is mental health?
Yeah.
Right?
Yeah.
How does that impact me? Well, in fact, there's nothing wrong. You're not going to get in trouble by God or something like that because you didn't pray enough, right? And if we could think about, going to the doctor if you, break a bone in your arm, right? You can also go because you aren't feeling so great, or because you are feeling depressed and you are struggling.
Right. Yeah.
So those are the kinds of messages that we sort of say consistently to help folks and, get invited to the conversation, if you will.
Yeah. And you're also able to have these conversations and to provide these resources across the gamut of age. So you've got from your youth all the way up to your seniors. I was really impressed by some of the testimonials from the young people, because a lot of what they're talking about are some of those social drivers that they're getting access to resources that help to boost their self-esteem, that help them think differently about themselves, which will have a huge positive impact on their mental well-being. And so I commend you that too, because what you're doing there in part is you're breaking that cycle of stigma, because you're reaching that younger generation. So where did you start? Did you start with serving the all age groups? Did you start with adults first? How did you start?
Yeah, thank you for that question. So we actually started with adults 18 and over. And then I would say during the pandemic, because we were getting so many requests for services, I remember this one mom called me back. And she said, I've called all 3 of the referrals that you gave me, and pretty much all of them have said to me that they don't have capacity to see my son at least for a year. What am I supposed to do with that when I can see the cuts on his arm? What am I supposed to do? Who's going to help me? And then she shared, a more personal story. And basically she was saying, I'm afraid. What am I going to do? I'm not going to call 911. I'm not going to take my son to a hospital. And so I'm really asking you, what else can you do? And it was at that point that I said, you know what, I've got to do something. because those calls were coming in pretty consistently, and no referrals were going to be good enough because they just didn't have room.
Yeah.
And we still see that now, but at least they have a place to go pretty regularly, and at least we can say these are the options that we currently have to be able to support your child.
Yeah. Dr. Hankerson, in his comments, he mentioned that one of the things that he wanted to see happen was to be able to replicate this program to churches across the country. Have you started introducing this to other faith-based organizations, faith-based communities across the country?
We have. We've had several conversations with several faith-based organizations, and not just Black churches. I just want to be very clear about that. We've partnered with churches on the Upper East Side. We've talked to churches in Memphis, Tennessee. We've talked to folks who are interested in Arizona. Nothing has quite gotten off the ground, but there are folks who are certainly interested in this model. And so we're very excited about being able to replicate that. Of course, it takes, some resources to be able to do that, but we're very much interested in doing that.
Yeah. And I love the fact that this is not a program that would be restricted to a Black community or, one denomination, because the idea that you can wrap these resources around a faith-based community and really tapping into what already resonates with that community, what they're already, who is already a trusted messenger, what they already could perceive as a trusted message, and being able to mesh those things together. And that's something that you can do in a church in New York. You could also do it in a church in Arizona, a church in California. It could be done in a Black church, a white church. Let
me just add, because we're able to talk to folks who, are running mosques, right? And talk to those faith leaders.
Yeah.
We've gone and visited synagogues, right? So we're super excited that this model is replicable. And we'd love an opportunity to talk to other faith leaders about how they can also provide mental health support to their congregation.
Well, I'm glad you added that, because I was about to ask you for, because we have listeners today, both from professional organizations, from funders, from philanthropists, but we also have listeners who are going to be from communities who I'm sure would love to see a program like this come to their community. What would you like to say to any folks out there who are saying, hey, I would love to have this come to my church? Any advice on where to have them start?
Yeah, I would say, start by looking at our model, right? So you can go onto our website directly, take a look at the demographics within your congregation. I would say also think about surveying, right? So we want to also make sure that we're not just being prescriptive blindly, but that we're actually asking questions of the people that we're looking to serve about what's important to them, how they would like those services delivered, right? We don't want to make assumptions, and to know that programs and services are always much better when you include the voices of the people that you're looking to serve and give them an opportunity to have voice and choice in what they're receiving.
Yeah.
And again, we're happy to have the conversation and share some insights around how to do that.
And now on the other side of that, for any funders, any philanthropists, any organizations out there who have resources, what would you want them to know? Why should they invest in Hope Center Harlem?
Well, they should invest in Hope Center Harlem because we are an excellent model for providing services and care to the community. We're a trusted entity. We are looking to expand our capacity. I think I mentioned earlier that we still have over 250 people on a waiting list. And so even with the number of clinicians that we have, we can certainly do so much more. So we'd love to expand our capacity. We're also looking to see if we can do more around mobile mental health. And we'd like to take this show on the road, if you will. So we're looking to what we called expanding to networks of hope. And so we're looking to be in other neighborhoods across the country and of course across the city as well.
Well, you get a hearty amen from me, Dr. Green. Thank you so much for sharing on your program. This has been just incredible. I hate that Pastor Warren was not able to join us today, but we so appreciate you, and we so appreciate the work that you all are doing there in Harlem. So again, thank you so much.
Thank you. It's been a pleasure sharing a little bit more about our services. And please, I would love for folks to check back with us. We have a newsletter that goes out monthly, and then we have information on our website where you can catch myself, Pastor Mike, and Dr. Hankerson sharing more about our programs and our services, and most certainly about our resources and certainly about our story. So thank you.
Thank you. And thank you to all of our presenters today, Dr. Mancini, Dr. Prince, Mr. Jeff Winton, Dr. Sonya Richardson, Dr. Lena Green for being with us today. And also thank you to Congresswoman Bonnie Watson-Coleman for sharing such encouraging and powerful remarks. And thank you to you, our audience, for joining us today. Your feedback is very important to us, so please take a moment to fill out the survey. And as a reminder, if you would like to learn more about AFSP, please visit our website at afsp.org. You can also learn more about The Upright at afsp.org/The Upright. And remember, if you or someone you know is living with mental health challenges, get support. And if you or someone you know is in crisis, you can call or text 988 to be connected to a trained counselor who can connect you with the help, with the services, with the support that you need when you need it most. Because you matter. Your life matters. Your pain matters. You are not alone. And we want you to be here tomorrow and every day after that. Thank you for joining us, and enjoy the rest of your day.